So the first part of the examination sequence is going to be in standing. First one is the Ottawa ankle rules. There are a couple things or a couple requirements you need. So once your patient has any sort of pain and cannot weight bear upon an injury or immediately after an injury, you must order an x-ray just to make sure you can rule out a fracture. Same goes with if you put them in standing and they cannot weight bear, it's important to order an x-ray so that you can either rule in or rule out a fracture. Up next would be manual muscle testing. You have two muscles that you test during standing. The first one's the gastrocnemius, the second one's the soleus. For the gastrocnemius, what I'm going to have the patient do is I'm going to make sure they can, for one, on one side, I'm going to explain to them that they're going to stand on one leg, specifically the outside leg will be the one they stand on, and then with the other arm, they can balance themselves with the table. I'm going to ask the patient if they can plantar flex or have their heel come off the ground. If they can get it off the ground 5 times, that's perfect strength. So if you can go ahead and on that side go up 5 times. 1, 2, 3, 4, 5. Great job. And that one's for the gastrocnemius. The next one is going to be the soleus. It's going to be plantar flexion assessment 2 for muscle strength. For this one, the only difference is you're going to have them bend the knee a little bit. Same sequence, have them come off have their heel come off the ground 5 times. You can go ahead and do that. Bend the knee a little bit. 1. And of course, if your patient has any balance issues, make sure to guard them.
Okay, now for the sitting sequence for ankle and foot, you first want to finish off the Ottawa ankle rules for the criteria. So Cesar mentioned the first part about standing and bearing weight, and so the other parts now, you want to just palpate the medial and the lateral malleoli right here, and then you want to palpate the base of the 5th metatarsal, so that's right here, and then you can also palpate the navicular bone right here, and then so that if there's no reproduction of symptoms or pain and tenderness, then you're good to go ahead and continue the examination. And then for the next part, you want to just inspect the ankle and the foot, make sure everything looks okay. So, check for inflammation and swelling. You can even, do a girth measurement here if you want, and around here, and then compare it to the other side to make sure it is inflamed or swelled, or maybe just both feet are naturally like that. So then also you want to just kind of feel the skin. Is it warm? Is it tender, anything like that? So after that, you can then go on to the range of motion. So first we'll do inversion. And if you use a goniometer, the anterior approach is preferred. So you line up 3rd metatarsal and access is between the malleoli. And so then you just go ahead and you have the patient invert. Okay, and then you can correct them and make sure your goni's all lined up. And then you take that measurement, and normal for inversion is 30 degrees. And then next we'll do eversion, so it's just the opposite way. So you go ahead and have the patient do it, and then hold it and line up your goniometer the same points, and then I'm getting about 18 degrees, and normal is 20 for eversion, range of motion. And then we'll do the MMT. So it's for tibialis anterior, dorsiflexion plus inversion. And so what you'll do is you want to palpate right about here, and you have them, so you bring them through the motion, make sure that they can do it 3 times, and then you palpate, make sure that they can do it there. So go ahead and do it 3 times. And then your direction of resistance is going to be the opposite. So then you just hold and ready and min, mod, max, and relax. And so if they can sustain through min, mod, and maximal resistance, then they get a 5 out of 5.
For the supine section of the examination, we're doing range of motion, we're doing home and sign. So for range of motion, we're going to go through plantar flexion. What you first want to do is you're going to have your patient supine. You're going to put a pillow right under their knee. The point of putting the pillow under the knee would be need to put the gastrocnemius in slack so that whenever you go through dorsiflexion, the gastrocnemius won't limit the dorsiflexion. But we'll start off with plantar flexion. The normal range is between 0 to 50 degrees. So for your stationary arm, you want it to be in line with midline of the leg, and then for the movable arm, you want it to be in line with the midline of the fifth metatarsal. The axis is actually where those two lines meet. So the midline and then both these segments, all right? So you will plantar flex them as far as they can. Get the reading, and then you will report it. Up next will be dorsiflexion, same process. The stationary arm and the movable arm are actually the exact same. So, go and go through the range. Record, and then do it on the other side. For the next segment is the Hohmann sign. So this detects DVTs. For this examination part, you want the leg fully extended. The clinician will passively dorsiflex the patient's ankle. All right. You ask your patient, did you feel anything there?
No.
So if they report that they did, specifically pain in the calf, then that would be a positive test. Something to note about the Hohmann's exam is that it has a very low sensitivity and a very low specificity for diagnosing DVT.
The next part of the examination will be done in sideline. We're going to do the manual muscle test for inversion and eversion. So first we'll start with eversion. You bring the patient through the motion, and then you have them actively do it while you palpate fibularis longus and brevis. Perfect. And then you bring them about halfway and you resist, min, mod, max. And she was able to withstand through maximal resistance, so that would be a 5 out of 5. And then for inversion, you are lying this way. It'll be the bottom leg, and so you'll bring them through the motion 3 times. And then you palpate tibialis posterior, and you have them do it 3 times on their own. Bring them halfway, and then you have them resist, min, mod, max. Perfect. And she was able to resist maximal resistance, so that would be a 5 out of 5 as well.
For the prone portion of the examination, we're going to do the Thompson test. The Thompson test tests for an Achilles tendon rupture. For this examination, you'll have your patient prone. What the clinician will do is clinician will squeeze the gastrocnemius and look for plantar flexion. If there's no plantar flexion, then you can assume that there was a Achilles tendon rupture.